right, so it's right at 10 o'clock. I'm Dr. Leslie Rolph. I'm from UTMB in Galveston, Texas. I'm going to talk about VNGs, what to look at, how to read them, so you don't have to read just the reports, but the waveforms as well. All right, so first things first, what are we looking at? So the ocular motor, what things are in ocular motor? Tracking, saccades, optokinetic, and gaze. In positionals, you have Dix-Hallpike, sitting, head right and head left, supine, head right and head left and center, body right and left, and at 30 degrees, head center. And you have your calorics, bithermal, monothermal, and ice. You also have rotary chair, OVIMPs, CVIMPs, posturography, VHIT, etc. I'm not going to talk about those today, but you also have those available. So what instructions do you as ENTs need to give patients? Don't scare patients, please. Many medications have effects on test results. Please have them keep taking their long-term medications as they won't get out of the system. We want them to keep taking heart medications and things like that. They should discontinue their sleeping pills, tranquilizers, barbiturates, antihistamines, antidepressants if they can. I know we've told our ENTs here that if they can't get off them, they can't get off them, but they will affect their VNG tracings as they cause them to be sleepy and things like that, and have different central effects. And we ask them to note that in their ENT report. Do not tell the patients they will get sick, vomit, etc. We don't want them to be anxious during the test because anxiety can definitely affect dizziness and testing. Tell them we do want to try to get down to their dizziness and try and figure out what is making them dizzy. So the test may make them dizzy, but we want to help them try and get down to the bottom of this. All right, so first things first. We do want them to cooperate. We do want them to participate in the VNG. Visual acuity is always a must. If they're blind, they can't do ocular motor because obviously they can't see the target. Again, medication and drugs have an effect on the central nervous system and what we're asking them to do. Age has an effect, especially in ocular motor. The tracings aren't as clear. So the older you get, the more problems you have, especially with dizziness and everything like that. Anxiety, again, has a big effect on VNG and tasking and everything like that. All right, so I do have a couple of things. So the first thing we're going to talk about is gaze. I don't know if y'all know what this is, but so gaze, you're looking at a dot. This is actually a smiley face, but my picture didn't come out too well. So you're looking at it, and it's going to go to the left and then the right. And we're trying to see if they can track that stimulus clearly without nystagmus, of course. All right. And you do it horizontal, and then this one is vertically. So then it's going to go down and then up. All right, so what we want to know is, can the patient reach and hold their gaze vertically and horizontally? And we can do this. We have several different stimuli. A smiley face, we can do a red square, we can even do Mr. Potato Head. Doesn't really matter. I don't care that they know what they're looking at. I just care that they're looking at something. It can be blurry. If they have double vision, I ask them to look at one of those dots. It doesn't matter as long as they can do the task. And what are we looking for on gaze? We're looking for nystagmus. We often see square wave jerks, and this is what the tracings look like. So if you look here on the left one, it's pretty clear, clear and straight line. That's what we're looking for. I don't really care about this little hump at the beginning. He looked away for a second, this patient looked away, but it's pretty straight, clear. But if you look on the right, we have a little bit of some noise right there, but that's okay. And again, this is vertical gaze. Maybe he looked away for a second, maybe he blinked, but it's still nice and straight, no nystagmus, anything like that. So ocular motor. So smooth pursuit or tracking. Can the patient follow that smiley face, dot, whatever, as it goes slowly left and right? It's gonna, we do 3 frequencies. So it's gonna go slow, and then it's gonna get faster, and then faster again. There, it got faster. It's gonna get faster one more time. Perfect. And this is what the tracings look like. There we go. So the first one is really slow. It's nice and clear, and the patient can do the task. You can see as it gets faster, it's not as clear, but the patient can still do it. So what are we looking at? We're looking at gain here at the bottom. Everything's above that gray striked out area, and that's what we want. We want it as close to 1 as possible. See in this upper right, it's 0.97, 0.98, and 0.95. That's what we want. And then we're looking at asymmetry. Can this patient do it equally left to right? Yes, this patient can. If you look on the bottom, this is some overlying square wave jerks. This can be abnormal if the patient is 25, 30, but if the patient is 80, 90, this may be normal for him. You just have to take that in consideration. All right, we're gonna go on. Yep. All right, so next is saccade. See how that dot jumps around randomly, left, right, at different frequencies? Our VNG system only does it horizontally. In our rotary chair, we do have saccades, and it can do it vertically as well, so it depends on what system you have. This goes on for a while, so I'm gonna, I did. All right, so what are we measuring in saccades? We're measuring latency, velocity, and accuracy. So if you have a slowing of these saccades, it can be consistent with a CNS lesion, degenerative, like degenerative conditions, basal ganglia pathology, cerebral disorders. Could also be drowsiness. The patient is really tired, you have drug effects, or an ocular motor weakness. If it's very fast with a short latency, it could be due to technical difficulties with the system. Rarely a CNS or ocular pathology, like an ocular flutter or something like that. If it's asymmetrical velocity, it could be ocular nerve or muscle pathology like INO. The eyes aren't moving together, often seen with INO. So you'll have an asymmetry there as well. Short latencies can be due to artifacts or the patient not participating, not anticipating the target. You'll see very short latencies there. Prolonged latencies, the patient is very uncooperative, not paying attention, or it can be a CNS pathology. You'll often see, we repeat, if we see an abnormality on this test, we may repeat this, so you may have a repetition of this test. Asymmetrical latencies, can be lesions in the occipital or parietal cortexes. Delayed saccades, again, can be drugs, attention, or other central findings. And here are some, hold on, I'm gonna go into accuracy. For accuracy, you may have them overshoot it, like they're anticipating it. They can hypometric it, so they can undershoot it. You'll see some flutter or multiceps. Or you can have like a drift to it, like a glissade to it. And I'm going to show you some examples of this. I have not seen any pulsion on any patient, but that's a pulling to the left or to the right on vertically saccades. So let me show you. So on this top left right here is some hypometric. So sorry, these are not clear. I tried to get them as clear as I could. But so it goes to the right and the eyes jump up and then come back down. So it's overshooting that target right there. This is some undershoot. So if you see, not on this top one, as we go down here, the eyes don't quite get there on the bottom. So they're undershooting that target right there. This is flutter. See how the eyes kind of do this fluttering motion on everything. So one, he's undershooting everything. And you have this flutter of the eyes. And you could see that in the eyes as you watch the eyes as well. On these multi-step saccades, as you see here on this bottom right, I have a couple different examples of this. You see the eyes as they jump, they kind of do these stair steps to get there. That's a multi-step saccade right there. And I have a couple more. Here's this pulsion. I haven't seen this in any patient, but they're trying to do this. They're trying to get there. Again, you see this kind of multi-step saccade. It's almost like they move their eyes, but they have to do a catch-up saccade to get there. That's what that pulsion is. And here's a glissade or post-saccadic drift. They're trying to get there, but they kind of have to, instead of doing that, that step, they kind of do a curve to get there. It's like they're slow and they're trying to get there, but it's curved to get there. And that's what a glissade is. All right, so this is the graphs at the bottom that you'll see. So this is your velocity here, and you'll see the tracings up here. So you're looking to see on the velocity, is it normal velocity up here? So all this is normal here, or is it slow down here? Here's your accuracy in the middle. Is it normal? This guy's normal, overshoot or undershoot in the accuracy. And here is latency. Is it normal or is it delayed? So those are your saccades. So next is OPK. So if you do your OPKs in usually a VNG, it's usually a fixed OPK. It's not a true OPK like you see in a rotary chair where you have a full field all around you. It's just one dimension right in front of you, so like on a wall. So on this one, you'll see it's going to go left, kind of like a train going past you, and then it's going to go right. And this is what you're going to see as the tracings. All right, so what is an OPK? An OPK are movements that are generated by moving fields, like you're looking at a train or you're looking out of a car window. You're looking at the symmetry between them, okay? So you're actually looking for nystagmus generated in both directions. Here's your left and here's your right. And you're comparing your gain in your left and your right. So this left is 0.85 and your right is 0.78. And here's it's plotted together, your gains plotted together, and you want it above the gray area right here. That gray area is, I think it's 0.6. So you want it above there, and both are normal. Here's an abnormal down here. See how he just can't quite do it here on the left, and on the right it looks bad too. He's kind of getting it, not really. So both are abnormal. So when you're looking at this, it's suggested of a CNS pathology. You often see this in severely motion sick patients. When you start the test, oh my gosh, they can't do it. They want to close their eyes. They get really, really nauseous. And they want you to stop the test. All right, so next, we're going to talk about positionals. So first, what are we looking for? We are looking for nystagmus on positional testing. When you see the nystagmus, you want to know, one, does it fixate with a target? So then you shine you put a light to see if it's fixation suppressed. 2, does it decrease or increase in a certain position? And 3, what direction is the nystagmus? All right, so about the nystagmus. We're gonna, different types of nystagmus now. So square wave jerks. Square wave jerks are sporadic. They're horizontal, conjugate saccades away from an intended position, okay? And then they return back to that position. This is the most common abnormality you're gonna see on a VNG. Some of these can be healthy, some are not. You do see this with increased age. If you see this in a person with a younger age, it is suggestive of a cerebellar disorder. So here are some examples of square wave jerks. Here's a little bit here on the left, but here's a huge one right there. All right, so other types of nystagmus. So you have Brunn's nystagmus. Low frequency, large amplitude. It's in the horizontal, not the vertical. And it's when the patient is looking towards the side of a lesion. High frequency, small amplitude when they're looking away from the lesion, such as usually get this in CPA mass lesions. They have been recorded in stroke patients though. Congenital nystagmus from birth, you can get them. Rebound nystagmus, so when you have nystagmus in a primary position, which is provoked and prolonged eccentric gaze. So it appears after the eyes return to primary position. Endpoint nystagmus, so when you're doing, when you're looking at the eyes and they look to the right or left, you may get it, and that could be normal. You have periodic alternating nystagmus. It's a jerk nystagmus, horizontal jerk nystagmus that changes direction. It could be acquired, it could be congenital. You also have upbeating and downbeating nystagmus. It's what it says. All right, so here's some spontaneous nystagmus testing. So here you see the testing on the left. Don't really see very much. So what you're doing in spontaneous nystagmus, this fixation one, you're looking at a light. And then in the no fixation, you take out that light to see if they have any nystagmus. So here in the middle, they're looking at that light. They don't really have anything. In the one on the right, look at that nystagmus. That horizontal nystagmus is the top. it's a left horizontal tracing you're seeing, and then the left vertical is at the bottom. So they do have some spontaneous nystagmus. Here on that top right, you do see some square wave jerks right there. So again, here in this one, without fixation, you have some vertical nystagmus right there, and it happens to be downbeating. All right. So next, BPPV. I'm not going to go into how to do Dix-Hallpike or anything like that, but this test is used to look at the presence of a BPPV. There are several modifications for patients with cervical problems, like a side-lying or fully supported Hallpike, etc. But if you look down here on the bottom, this is what you're going to find. For a posterior canal BPPV, you're going to find a rotary upbeating nystagmus that inverts when you sit them up, okay? And I've listed some treatments, whether you do treatments or you send them for, to the audiologist or to PT or vestibular therapy. With a horizontal canal BPPV, you're going to see horizontal nystagmus. Oftentimes, we're going to do a roll test to see if it's geotropic or ageotropic. And then here's the treatment for it. For an anterior superior canal, which is very rare, you're going to see rotary downbeating. And then the treatments are same as posterior. All right, so these are some tracings for Dix-Hallpike. So here we go. So you're going to do supine first. There you go, not very much. Come up and do sitting, not very much. So it's a negative Dix-Hallpike on that left. But look at this right. So here we have the right. We see some nystagmus. Here, bring them up to sitting, and you have some. All right. All right, so next is sitting. I got a colleague to be my, to get me to take some pictures of her to show you what a sitting is. So we do sitting head right and head left to see if nystagmus becomes worse. So here we go. So sitting head right, not really very much. You do see some square wave jerks here. And then we go to head left down here. Still a little bit of square wave jerks. You're probably going to see the same thing in still these little bit of mini square wave jerks on the spontaneous. So I don't see any nystagmus, so that's normal. And then we're going to go to head right, head left, and head center. So we do head center first, then head right, and then head left. Again, we're looking for all those nystagmuses. What direction it is, how much it is, does it get worse in each direction? And then we're going to do body, head right and head left. So she's up on her side, looking to the right and to the left. If you had a positive Dix-Hallpike, we usually put her in the position, wait about a minute or so for that nystagmus to go away and see if there's any nystagmus in any one of these positions. So if you look here, here's a positional body. And you have some horizontal nystagmus. If you look right here, it's a left beating nystagmus, 5 degrees. And in body right, it's a right beating nystagmus, 6 degrees. So it changes position in body right and body left. And then we have head 30 degrees. And so we bring her up and see if that changes. Here we have two examples. On the right, here's a normal, no nystagmus on head 30 degrees. And here on the left, we have some nystagmus on head 30 degrees. All right. So now we have calorics. We can do water or air, cool or warm, bithermal or monothermal. Cool and warm, we have 30 degrees Celsius for cool and 44 degrees Celsius for warm for water, 24 degrees Celsius for cool and 50 degrees Celsius for warm for air. Here we do monothermal. If monothermals are abnormal, then we'll do all four. Calorics, patients don't really tolerate calorics very well. So the least is better for them. If they have a weakness, a bilateral weakness, then we'll do ice. So we only do ice if they're less than 20 degrees total response to see if they have any function. So these are the formulas. The canal paresis junkies formula, that's what it is. Most systems calculate that by themselves, and will split that out for us. Depending on what criteria your clinic uses, whether they use 20 or 25, you'll have to ask them. We use 20 here for a weakness. Then your system will also calculate directional preponderance. Anything greater than 35 is abnormal. A lot of places don't put any value into this directional preponderance value. They don't look at that. They only look at the canal weakness. You do have hypercaloric responses. If you have a total response of 140 degrees per second or greater, it's considered to be a hypercaloric response. You see this in anxious patients or people who have migraines, rarely a CNS disorder. Usually it's vestibular migraines or anxiety. All right, so this is what you're looking at. No fixation, fixation, and post-fixation. You'll also see irrigation over here as well. So you're looking for nystagmus here. On the fixation, you want it to decrease 50%, at least 50%, to see if they can fixate that nystagmus. And then post-fixation, you want to see the nystagmus come back, but to a lesser degree as the no fixation. So sometimes you'll see an inversion or perversion. An inversion, usually the VNG system will say you have an unexpected beat direction. You'll see it in tympanic perforations or congenital nystagmus. Rarely you'll see it in brainstem diseases, but it has been noted. And it's just something to look at. Usually with tympanic perforations, we will do air calorics, but you'll often see that unexpected beat direction. Perversion is when you'll see vertical nystagmus instead of the horizontal nystagmus. So here are some examples. So this is what you'll typically see. You'll typically see this chart right here. Here's left warm and left cool on the left side, and your right ear on the right side. And if you see at the bottom, your right ear response, your weakness is your right ear of 53%, so that is significant. So your right ear is your weaker ear. Your directional preponderance is 14 degrees, and your total eye speed is 77. And we don't have any spontaneous nystagmus. If you look over here on your right, here is your no fixation of your response. So this is just your nystagmus during the right after the irrigation, where it's calculating the calorics right here. And you can see how as the after it irrigates, you should see the nystagmus should start and ramp up, and we're calculating it right as the right at the peak of the nystagmus. Then we turn on a light to see if it fixates. It should fixate at least 50%. That's right here. And then after, you should see that nystagmus come back. And I don't think on this one we calculated it. But at least you have that, the caloric weakness here. So that's a unilateral weakness. Here's a bilateral weakness. It did not even calculate down here. That's interesting. If it doesn't calculate, we'll either force it to calculate. We can go in there and manually do it, or we get out pen and paper and calculate it ourselves. So this is a bilateral weakness. You have 5 degrees with warm, 0 with left. Your right ear, you have 0, and you have 4 degrees with your cool. All right, so I have a couple cases. All right. So here's my first case. We did do an audio on this patient. So this patient has a high frequency right ear hearing loss at 4 and 8K. As you can see, here's the ocular motor. Not much there. No nystagmus in your gaze, vertical, horizontal, spontaneous, or head sitting. Here's your positionals. So here's your center. A little bit of square work dirt, not much. Here's your head right. So you have some nystagmus there. It's left beating at 5 degrees. Your head left, not very much, but then it starts. So you do have some nystagmus there. It's right beating and down beating of 3 degrees. So some nystagmus is, nystagmus of 4 degrees is abnormal. Anything less than that is abnormal. So we're looking for a nystagmus of 4 degrees or greater to be abnormal. So here's body. So this patient must have blinked here, all this blinking. And or as you put him back, sometimes the goggles move, and you kind of have to use your hands and get the goggles back on. So that may have been what happened here. But then they got him back on, and look at that nystagmus. So in body right, you have left beating 9, down beating 7. So it's like an oblique nystagmus there, to the left down. And then they did body left, not much there, and then it starts. You have right beating 4 degrees. All right, so then you have saccades. So if you look at these saccades, the patient can do it. Little bit stair step there, comes down and up, down. Here, it's kind of borderline. It's right on that line of abnormal and normal. Accuracy is fine. Latencies are fine. Usually if they cannot do it at all, it's way down here in the gray. So borderline is actually okay. They repeated it to see if it got back normal. It's fine. I mean, it's still the same. It didn't change. Look at pursuit. Your gain is okay. Your asymmetry is okay. Your OPK fixed is normal. Your asymmetries are fine, your gains are fine. Here's your right ear. Your right ear was weaker, 39-degree weakness, unilateral weakness. Your total response is fine at 69. All right, so what do we have? We have in head right and body right, we have more nystagmus than in the left positions. Therefore, we know it's an uncompensated lesion, and the lesion's on the right. And we also know we have a unilateral right ear weakness. But I didn't, hold on a second. I did have history in here, and I don't know why it didn't show up. So my ENT diagnosed this patient with vestibular neuronitis and sent this patient for vestibular rehab. This patient did have, we did send it for an ABR due to the asymmetrical hearing loss, but the patient didn't show up. All right, so I have one other case. I do have history on this case. All right, so this next case was a 44-year-old female with asymmetrical hearing loss, left oral fullness and tinnitus. She reports changes in pressure bring on this wooziness, which causes her to be a little lightheadedness for a couple seconds. She denies imbalance, so only this wooziness. She has mild headaches occasionally, which she says may be related to her sinuses. Her dentist thinks she may have TMJ. She's had 3 episodes of this, these dizziness episodes, these wooziness episodes. Her first one was 6 years ago that went away in 3 to 4 months with nausea and vomiting, which came on really suddenly. The second one was last summer while she was moving. She says it was milder than that first one 6 years ago. However, she said everything started to close in, the vertigo started, and it lasted weeks. And then this third one she described as that wooziness. So that first one was really the worst one. All right. So here's her VNG. All right, so we have here gaze. So here's horizontal gaze. Not much there on the left. That right looks worse than the left, but it's actually normal. She has a couple eye blinks here. 1, 2, and 3 eye blinks, but no nystagmus noted. That's what we're looking for. On the vertical gaze, again, eye blink, eye blink, eye blink, eye blink. So again, this is normal because if you look at the eye blink here and the eye blink, it actually lines up, so that's not nystagmus. And same thing here. It's pretty smooth, but this is consistent with that eye blink up here. So that's normal. When I'm looking at this, I actually have the eye videos, so I can look at it right when it blinks and look at this at the same time, so it's nice. All right, so spontaneous nystagmus. Looks pretty flat. These are your eye blinks, not much there. Eye blink there, eye blink there, pretty flat. Positional head sitting, same thing. This person is definitely an eye blinker. Same thing, I don't see much nystagmus. I see lots of eye blinks, not much there. All right, Dix-Hallpike. I don't see very much nystagmus, maybe something there, but it's not persistent. It doesn't get worse. I still see some eye blinks, not much there. Dix-Hallpike left. Not much there. little bit of eyes all over the place, but nothing like really, doesn't look like nystagmus very much at all. I sit her up, nothing. So both negative. All right, positional head supine. Maybe something there. I'd probably, when I look at it, I can look at what degree that is, and it's probably less than 4. Sorry. Her eyes are kind of going all over the place here, but no nystagmus. A little bit of square ray jerks, but she may be looking all over the place as well. Not much there, not much there, nothing. All right, positional body. Nothing, maybe a little bit of nystagmus, but that looks more like an eye blink there. Body right, oh my gosh, look at all those eye blinks. Still nothing there. Sit her up at 30 degrees, not much there. I'd probably look at how much this is. Still, that's maybe 1 or 2 degrees. It's normal. Saccades, normal. Borderline here. The other eye is normal, normal. Normal accuracy, normal latency, that's all normal. OPK fixed, normal. My caloric. So everything was normal except this left ear response was weaker. Oh my gosh, what is going on? Did she have this weakness before? I don't know. So what other tests would I like on this patient? Rotary chair. I'll tell you, rotary chair was normal. Maybe an ECOG. We did do an ECOG on this patient. She had an SPAP ratio of 54. So that's abnormal. She did have an audiogram in 2000. This patient, we did her first one in, her VNG was in 2014. So she had this left asymmetrical hearing, low frequency asymmetrical hearing loss in 2014. She has recently come back and her hearing was normal. So on the VNG, we had a right caloric weakness, positive ECOG on that day, consistent with fluctuating hearing, nausea and vomiting, or she complained of fluctuating hearing, nausea and vomiting, vertigo in the last, in at least those first episodes. She had that headache. She had some visual changes, like it was zooming in before that third episode at least. She was diagnosed with Meniere's disease. Still didn't explain the headaches or facial pain and visual changes, but she had migraine, and TMJ was also in the differential. MRI was negative. She did do some blood work for an autoimmune that was still pending at that time. She has followed up with the dentist, and they're still considering migraines. So that's what we have on there. They diagnosed her with Meniere's disease because of that, that weakness. Some migraine patients I don't find, some Meniere's disease patients, I don't find any caloric weakness. It just depends. So that's it for my presentation. Although I did that fast, if I could, let's see if I have it.
Dr. Rolph, thank you for your presentation. That was a topic that has not been covered with this consortium, and obviously very apropos for learning within otolaryngology and audiology. So thank you for that.
You're welcome.
Does anybody out there viewing have any questions on the chat or Q&A? And you may have covered this, Dr. I've had to step away for a second, but from Dr. Singh, it says the first case you presented was a nystagmus in the body right position, left or right beating.
Let me see. The first case, it was body right.
Body right, okay.
Mm-hmm.
Are there any other questions out there for Dr. Rolph? Okay. If not, thank you again for joining us. And we will get going right at 11 a.m. Dr. Roy is going to do the last talk of the day on resident education and quality and safety in otolaryngology, which it's an awesome talk this day and age. Very apropos as well. So we'll see you all in about 14 minutes. Hi, Dr. Roy.
Hey, good to see you, Dr. Comer. How you been?
I'm good. How are you?